Now let's talk about coronary circulation. What are the important points we need to remember for the USMLE? First, whenever we are talking coronary circulation, let me remind you. One, we have to remember about control. We spoke of this before. Can you recall for me what is responsible in the control of blood flow to the coronary circulation? If you say adenosine, then you're correct. What's the next point we have to talk about and remember? We have to remember about the pattern. And what do we mean by pattern of control? Well, we know that the heart, we have the left side and the right side. The left ventricle is a more powerful pump than the right ventricle. So that when the left ventricle contracts, because it's such a powerful pump, it squeezes and occludes to a large extent the left coronary vessels. Because of this, during systole, flow to the left side of the heart is diminished. Whereas the right side of the heart, because the right ventricle is not such a powerful pump, flow is not as much diminished. Because of that, then in systole, the left ventricle is minimally supplied by coronary flow as opposed to the right side. Now, during diastole, when the heart is relaxed, now this is when flow to the left and to the right side is maximal. Conclusion: it is during diastole that coronary flow is maximum and the supply of blood to the heart is maximum. What's the third point that we want to bring to our attention? The third point we want to bring to our attention concerns oxygenation. Oxygenation. You must recall that the coronary circulation accounts for 5 to 10% of cardiac output. 5 to 10% of cardiac output. That means that the heart receives much less a proportion of cardiac output than the kidneys. Can you tell me what proportion of cardiac output the kidney receives? 20 to 25%. Now, let's look at this. The heart is receiving 5 to 10%, much less than the kidney. So how can the heart, whose metabolism is so high, how can the heart compensate and adjust for this rather lesser portion of cardiac output? It does so by increasing the ability to extract oxygen from the blood. In other words, extraction in the heart is among the most maximum in the body. What do we mean by that? For example, if this represents coronary flow to the heart, and this represents the heart cell, this is the heart cell. Blood is going in. This is the coronary artery, and on this side is the coronary vein. Blood is going into the heart. The Ch02 is about 100. Let's put it normal. Oxygen content 20%, volume. Because extraction is maximum, the blood that leaves in the coronary vein will have a very low Ch02 because of maximum extraction. So therefore we can say in the heart, the AV difference is very large. We can then make a statement or a relationship that AV difference is symbolic of oxygen extraction. Can you tell me what the AV difference in the kidney would be based on this concept? In the kidney, the AV difference would be small in the kidney. And why is that so? Because the kidney receives a large part of cardiac output, 25%. So therefore there is no need for the kidney to go into maximum and massive extraction. The analogy is simple. Imagine you're going to a restaurant. There are two kinds of restaurant. There's a buffet restaurant and there is a normal restaurant. Let's say the buffet restaurant, $7.99 and all you can eat. You can go to the buffet table as often and as much as you like. When you go to such a buffet restaurant, $7.99, one price, all you can eat. When every time you go to the table, your extraction is rather small. Maybe to impress people that you do not eat much. But at the end of the day, you are going to make 10 to 20 to 30 trips to that food table to get your money's worth. In other words, the supply is large. So every time you go, you are extracting a small amount knowing you can go again. But let us suppose you go to a restaurant where you pay $7.99 and you're allowed to go to the food table just once. What will be the extraction when you leave that table? Maximum. When you're returning to your seat, your plate is piled so high no one can see your face in front of it, because you are like the heart. Supply is down, so extraction is maximum. Exactly. That's the analogy I want you to remember when you think of the heart and you think of the kidney. So therefore, AV difference is symbolic of extraction. Whenever AV difference is large, as would occur in the heart, that tells me extraction. This means that I have a large extraction. That tells me that blood flow, blood supply is rather small. Now the pumping action of the heart, we said that the heart is very high in its metabolism, and we know that the work of the heart, which is basically stroke volume times heart rate, which is stroke volume, heart rate, cardiac output, that's the work of the heart. Therefore, anything that increases the pumping action of the heart, in other words, increase the work of the heart, cardiac output of the heart. For example, exercise. When you exercise, you are going to increase the work of the heart. What does that mean? If you are going to increase the work of the heart, then you are going to increase the oxygen demand of the heart. So what will happen to extraction? It will further increase. Hypertension is also an increased demand from the heart, because we have an increase in afterload. Because we have an increase in afterload, in fact, hypertension to the heart is like someone going to the gym 24 hours a day, 7 days a week, as I said earlier on. So hypertension, early hypertension, forces the heart to work harder. So therefore, because of this, increasing the work demand on the heart will increase the oxygen need of the heart and will force the heart to try to extract oxygen much more as it can. Now, this brings us to cerebral circulation. When we talk about cerebral circulation, again, principle. First thing, can you recall for me what is responsible to control flow through the cerebral circulation? Answer? That's right, arterial carbon dioxide. So the level of arterial carbon dioxide will determine flow through the cerebral circulation. Can you recall or help me to remember the relationship between arterial carbon dioxide and ventilation? Can you recall that alveolar ventilation is inverse to alveolar or arterial carbon dioxide? In fact, to be more specific and to be more precise, we can say that alveolar ventilation is inverse to alveolar carbon dioxide, and this is proportional to arterial carbon dioxide. Bottom line is, we are saying that ventilation affects carbon dioxide. So when we hyperventilate, quite naturally, we are blowing our carbon dioxide out, so the carbon dioxide in our blood goes down. When we hypoventilate, the carbon dioxide, of course, will increase. And this is what we are saying to you in this slide. Now, if we increase arterial carbon dioxide, what does that mean? We will increase flow to the brain. And if we decrease arterial carbon dioxide, we will decrease flow to the brain. Can you tell me what happens to arterial carbon dioxide during exercise? We are going to talk about this later on, but I want you to think about it. Can you tell me, and we have touched on this before, what happens to cerebral flow during exercise? Can you recall that? That's right. If you're thinking that during exercise, normal exercise, arterial carbon dioxide remains the same, and therefore you are thinking that flow, cerebral flow will remain almost normal, then your thinking is the way we want you to do for the USMLE. Now let's talk about circulation in the skin. Circulation in the skin. Again, let's recall, when we are talking about circulation in the skin, Let's go back to when we are looking at autonomic nervous system and extrinsic control. We said earlier on that the skin, the blood vessels in the skin and in muscles are innervated by alpha-1 receptors. These alpha-1 receptors, as we said before, are connected to the sympathetic nucleus in the brain, so they are innervated. We also said that we have beta-2 receptors in the skin, but these beta-2 receptors are non-innervated. We also have other receptors in the skin, such as angiotensin II receptors, AT receptors. These receptors all play a role in the dilation and the constriction of the blood vessels. Alpha-1 constricts. Angiotensin II receptors, they constrict. Beta-2 receptors, they dilate. So now, blood flow to the skin and to the muscle is via these receptors mostly. Alpha-1, angiotensin constrict, and beta-2 therefore dilate. So therefore, blood flow to the skin is mediated via these receptors. Blood flow to the skin, we can talk and divide it into two categories. Blood flow in regards to autonomic nervous system and non-autonomic nervous system. What do we mean by that? If it's the brain that's controlling blood flow to the skin, we are talking about via alpha-1, either stimulating alpha-1 or inhibiting alpha-1. If we stimulate alpha-1, the brain stimulates alpha-1, what will occur? Vasoconstriction, decreased flow, and at the same time increased TPR, but decreased flow. If we inhibit alpha-1, this would lead to an increased flow to the skin. Non-autonomic nervous system, what do we mean by that? This could be via beta-2 receptors or via angiotensin receptors. How can we stimulate the beta-2 receptors to the skin? We can stimulate the beta-2 receptors to the skin either via the blood, via hormones, or drugs. Hormone, of course, epinephrine. This is the hormone that will stimulate the beta-2 receptors and of course cause vasodilation. What about drugs? Beta-2 agonists. If we give a patient beta-2 agonists, and as I say this, I'm hoping in your mind an example of beta-2 agonists is flashing in front of your eyes. Are you thinking of albuterol and the family of albuterol? Very good. Beta-2 agonists can therefore vasodilate, and that is why one of the side effects of beta-2 agonists would be a decrease in TPR due to the effect also as well as on flow. It will dilate and increase flow to the peripheral vessels, of course, in sufficient doses. Angiotensin II, you recall from your pharmacology, angiotensin II, this will constrict and therefore this will decrease flow to the skin. So overall, when we are talking of cutaneous flow, in the exam, what should I ask and what should I pay attention to? Are they specifying how does the autonomic nervous system control flow to the skin? If they are doing that, then you should only think of alpha-1 receptors. But if they are talking about other factors, for example, non-autonomic nervous system factors such as hormones, drugs, then we are going to think of beta-2 receptors and angiotensin receptors. This leads us nicely to understand how our body controls temperature. How do we control temperature? To understand how we control temperature, by the way, by now you know that the normal baseline temperature is 37 degrees. So how does the brain maintain this normal temperature in our body? Let's start with biochemistry. Can you recall for me the main source of heat in our body? Of course, oxidative phosphorylation. Oxidative phosphorylation. And where is oxidative phosphorylation taking place? In the electron transport chain. Remember that in the electron transport chain, ADP is converted to ATP, and for that we must supply oxygen, oxidative phosphorylation, and whenever this occurs in this reaction, heat is released. This heat that is generated in oxidative phosphorylation in the electron transport chain is the basic source of body heat. Now that we understand, so the control of ETC is the control of body's temperature. This is from a source point of view. If we are going to control the body's temperature, quite naturally there are two ways to do this. We can either control this via the ETC or control it via heat loss via the skin. The skin being the largest organ exposed to the environment. So therefore, heat can be evaporated from the skin to the environment. So there are two ways the body can control temperature. Either by increasing or decreasing the ETC. Can you give me a condition, a clinical condition, where we have an increase in the ETC, therefore an increase in body's heat, body's temperature? Are you thinking hyperthyroidism? Excellent. In hyperthyroidism, the ETC increases. Can you tell me then what would you think is a condition, a pathology that will decrease the ETC and decrease the production of heat? Are you thinking of hypothyroidism? There are also some drugs that can increase the ETC, some drugs that can inhibit the ETC, for example, cyanide and so forth, which you did in biochemistry. There are certain drugs and side effects that can cause an increase in ETC, drugs that cause neuroleptic malignant syndrome, where we have hyperpyrexia, hyperrigidity of the muscles. ETC is involved, and that's why these patients have an increase in temperature, an increase in heat, because of the effect. So control of heat is via the ETC, or via we are either gaining or losing in terms of loss of heat in the skin. Now, in the normal physiology and the normal process of the body prefers to control the temperature via heat loss from the skin, or the opposite, conserving heat from being lost from the skin. Let's look at how this is done. Heat loss. There are one or two ways we can do this. If we want to increase heat loss, or we want to decrease heat loss, this must be linked to blood flow to the skin. If I want to increase heat loss, then quite naturally I should increase flow to the skin. Why should I increase flow to the skin? Because the blood will take heat to the skin. Now the heat can evaporate to the environment and be lost. So from what we've just said just now or earlier on, how can we increase flow to the skin? In fact, we can increase flow to the skin in terms of via the autonomic nervous system, but which branch? Alpha 1, stimulating alpha 1. If we give a beta 2 agonist in large dose, what would you expect to happen to flow to the periphery? Beta 2 agonist, flow to the periphery. Did we say the beta 2 can vasodilate and increase flow? Pharmacology then, would you be surprised if you're told that drugs that are beta 2 agonists given in large doses can cause hypothermia? No. The physiology is there to explain why. Because of the increased flow to the skin. Of course, side effects in large doses, of course. Now, if I want to decrease heat loss to the skin, what should I do? Quite naturally, the opposite, decrease flow to the skin. How can we decrease flow to the skin? We will have to do what? Again, via the autonomic nervous system, we will have to inhibit alpha-1. To increase flow to the skin, by the way, let me retrace this. To increase flow to the skin, I hope you did catch that. Maybe I did that just to see if you're falling asleep was looking at this lecture. Did you realize that I teased you, if we are going to increase heat loss, we have to increase flow to the skin? Are you falling asleep? And if to increase flow to the skin, do you stimulate alpha-1 or do you inhibit alpha-1? You inhibit alpha-1. So wake up now and pay attention. If I want to decrease flow to the skin, what should we do? Now we should vasoconstrict. And how should we vasoconstrict? We have to stimulate alpha-1. I hope you were not falling asleep on that one and you catch it. Very good. I'm proud of you. Now, this brings us now, ladies and gentlemen, to renal and splanchnic circulation. Renal and splanchnic circulation. We spoke earlier about organs that are intrinsically and extrinsically controlled. Let me remind you of that. We said whenever we are talking about regulation of flow, we said regulation of flow can be done intrinsically or it can be done extrinsically. Now you go ahead and name for me those organs that are intrinsically controlled. We said the cerebral, we said the coronary, and I'll pause for you to mention the third. And the third is exercising muscle. And in terms of extrinsic control, the major organs, we said the skin, and the second is resting muscle. Now we want to add to this. There are two organs that exist in both worlds, intrinsic and extrinsic. Who are these two organs? These two organs are the kidneys and the splanchnic circulation. The kidney and the splanchnic circulation. Under normal circumstances, the kidneys are intrinsically controlled, the blood supply or the blood flow under normal circumstances. However, under abnormal circumstances, control to the kidney and control to the splanchnic blood control is via extrinsic. So kidneys exist in both worlds. So the question is, an example, well, normal, everything is being normal, blood flow to the kidney, blood pressure to the kidney, everything is being normal, then it's intrinsically controlled. However, example, should we have a case of hemorrhage, which can lead to decreased perfusion to the kidney, a serious fall in blood pressure to the kidney, should I say more than moderate hemorrhage. We're not talking about a simple hemorrhage, a prick in the finger and a few drops of blood. We're talking of a more serious hemorrhage and a serious fall in blood pressure. Should this occur, then the brain takes over control of regulation of flow to the brain. Now this chart should help you to remember what we want you to remember in terms of blood control, especially the fact that the kidneys under normal circumstances are intrinsically controlled, but under abnormal circumstances are extrinsically controlled. So when we have a serious fall in blood pressure or hemorrhage that is more than mild hemorrhage, not a few drops of blood from the fingers, moderate loss of blood, this now will force the kidney to lose its own intrinsic control of blood flow. And now the brain will take over extrinsically the flow to the kidney. Now this brings us to the pulmonary circuit. What are some of the salient facts that we need to know about the pulmonary circuit for the USMLE exam? First and foremost, we must recognize, as we said earlier on, that the pulmonary circuit is a low pressure circuit. The second point, that the pressure gradient is small. We said that the pulmonary artery has a pressure of 15 and the pulmonary vein has a pressure of 5, all units in millimeter mercury. So therefore the pressure gradient is approximately 10 millimeter mercury. Third point about the pulmonary circuit. We must recognize that the pulmonary circuit, and perhaps the most important point, has a very high compliance. The pulmonary circuit is a very compliant organ. The tissues are very compliant. What do we mean by compliance? We said that compliance is change in volume for change in pressure. In other words, the pulmonary circuit can give me a tremendous change in volume for small changes in pressure. In other words, it's able to accommodate sort of like the veins, but even more so. Now, we can also say that the pulmonary circuit has this unique characteristic, that it responds to PO2. Whenever there's a drop in PO2, this can lead in the blood vessels to what is called hypoxic vasoconstriction. Hypoxic vasoconstriction, which can now lead to a decrease in flow. Vasoconstriction of the vessels in the lung. These are four of the most important or salient facts we should remember at this point about the lung. Maybe we can add another point. What can you say about flow to the lung? That's right. The lung receives 100% of cardiac output. All of the blood that is pumped from the right ventricle goes into the lung. So it receives 100% of cardiac output. That means that the lung has to be very sensitive to the volume of blood that comes to it. And this is why we can say the compliance of the lung is so large to accommodate this large flow of blood. Therefore, we can say, because we know that flow is inverse to resistance, and the lung receives such a large flow, 100% of cardiac output, this will explain why the lung also has, because of that, a very low resistance. It is referred to as a low resistant organ. These are 5 characteristics that we should bear in mind in terms of the lung. Having said that, how does this help the lung in its response to certain conditions such as exercise and hemorrhage, etc.? Let us look at that, because the USMLE likes to ask about the physiology of exercise, the physiology regarding exercise, physiology regarding weightlessness, as you did in endocrinology, etc. Those are important points. Now, the response of the lung to exercise. In previous discussion, we talked about the response of the cerebral circulation to exercise, the heart to exercise. Now we will talk about the lung and its response to exercise. And as I am saying those things, I want certain ideas to cross your mind. Response of the cerebral circulation to exercise. What comes to your mind? Blood flow, the same. Heart, response to exercise. What comes to your mind? Coronary flow. Increases during exercise. And why? Because of an increase in adenosine. Flow to the muscle, skeletal muscle during exercise. What happens to flow to the skeletal muscle during exercise? Increase. And because of the production of lactic acid. I'm glad you said that, and you did not say it has to do with alpha-1 receptors, because we already mentioned and we warned you to be careful that during exercise, the sympathetic activity has no role in terms of blood flow. Now to the muscles, that is. Now let's look at the lung in terms of exercise. What happens to the lung during exercise? When we are exercising, we know that cardiac output is equal to heart rate times stroke volume. When we are exercising, we are increasing heart rate and stroke volume. So therefore, cardiac output increases. So therefore, what would you expect to happen to the flow to the lung? The flow to the lung should increase. More blood is going to the lung because we are pumping more blood. If more blood goes to the lung, again, if we are increasing volume into the lung, then pressure should increase. But luckily for us, we said that the lung is what? A very compliant tissue. So because of that, because of the increased compliance in the lung, being very compliant, as the increased flow goes to the lung will now accommodate. By stretching, it will accommodate. Because of this, pressure is kept almost normal. If anything, a small increase, but we will accept it from a practical point of view to be normal. That is why during exercise in a normal lung, we do not develop pulmonary hypertension. Now, what would happen in someone who has a history of smoking, leading to calcification and stiffness of the arteries in the lung? When that person exercises, what will happen to pressure in the lung? That's right, pressure will increase. Why? Because there will be a loss of compliance in the lung due to stiffness of the lung. So a person who has a history of smoking, again, is at the risk of developing an increase in pressure in the lung during exercise. Pulmonary hypertension may occur for that reason. Now, when we exercise, what else can happen in the lung, apart from the fact that the pressure stays the same? So let's summarize what are some of the effects that would happen in the lung during exercise. We said that 1, during exercise, we have an increased flow to lung. We said that during exercise, because of compliance, because we have an increase in compliance, this will ensure and maintains the blood pressure. So pressure in the lung will remain almost normal. Maybe slightly increased, but that increase is acceptable and tolerable. For all intents and purposes, we say it's normal. These are the two impacts that will happen in the lung during exercise. By the way, as a side point, have you ever asked yourself, we said that deoxygenated blood goes from the right ventricle, blood flows to the lung. And then from the lung, blood flows back to the left atrium. And we all know, and we've all memorized since high school, that the pulmonary artery takes deoxygenated blood to the lung. This is deoxygenated blood to the lung. And here we have the pulmonary vein, which is taking oxygenated blood to the left atrium. Have you ever asked yourself why nature has changed? And for the first time in the body, and perhaps the only time, that we have an artery taking deoxygenated blood and a vein taking oxygenated blood. Now this has to do with pressures in the lung. For example, we said that the lung is a low pressure circuit, and the pressure in the lung is approximately 5 to 10, the pressure gradient, approximately 5 to 10. The right ventricle can develop a systolic pressure of 25 millimeter mercury. All numbers, all units are in millimeter mercury. The right ventricle can develop a pressure of 25 millimeter mercury. The lung has a pressure gradient, an average gradient of 5 to 10 millimeter mercury. Now, can you imagine if nature did not understand this concept of the pressure difference in the lung, and instead of having the artery taking deoxygenated blood, we have the artery taking oxygenated blood. Let me draw this so you can follow me. Here again, let's put it the way that normally it should have been. Here is the lung, and this is the left atrium. If we had the pulmonary artery here, and we had the pulmonary vein taking deoxygenated blood, as should have been the case, this is a pump that can develop up to 25 systolic millimeter mercury of pressure. The lung has an average of about 10 millimeter mercury of pressure gradient across the lung. Therefore, it will be very easy to pump blood from high to low pressure. But what will happen to the return of blood from the lung to the left atrium? Inherently, intrinsically, the pressure in an artery is about 15 millimeter mercury. If the lung is 10, there is no pump in the lung. Will the blood be able to return back to the heart, to the left atrium? Absolutely not, because it cannot flow from low to high. It cannot flow from this very compliant tissue with very small with very low resistance and low pressure. So nature had to do some re-engineering to accommodate the fact that because we want the lung to be very compliant, low resistant, low pressure, in order to accept 100% of cardiac output, in order to have that in place, that principle, re-engineering had to be done to switch it around so that, as you know, now we have the artery taking the deoxygenated blood. The artery has a pressure of 15 inherently, because arteries have low compliance. They're very, once you expand them, they snap right back. But the right ventricle is able to overcome that pressure of 15 millimeter mercury and pump blood right into the lung. Now the vein has an inherent pressure of 5 millimeter mercury. It is very easy now for blood to flow from high to low. Why is this changed? Someone asked you. The answer is because of the compliance and the low resistance in the lung. How does the lung respond to hemorrhage? Again, because of compliance. The important thing here to remember is compliant. The very compliant nature of the circuit. Of course, when we have hemorrhage, we are losing volume. So by decrease in volume, we are decreasing cardiac output to the lung. This means we are decreasing volume into the lung. And because of the compliant nature of the lung will now respond by contracting, by coming in, because of the fact that there is less volume going to it, compliance. And this is how this will now lead to an increase in constriction or contraction. Constriction is a better word, of the lung vessels in order to maintain pressure. Pressure now is kept normal. So therefore, in mild to moderate hemorrhage, pressure in the lung is maintained. The lung is able to accommodate for that because of its compliance. This now brings us to fetal circulation. Fetal circulation. In the exam, there is one conceptual question that they always like to ask to see if we understand fetal circulation. And what is that question? The question is, what would happen to the oxygen content in the pulmonary artery in a patient with PDA? What would happen to the oxygen content in the pulmonary artery in a patient with PDA? Would you expect it to increase? would you expect it to decrease? Would you expect it to remain the same? Or will you expect it to decrease, then increase? This is the concept that we want to teach. This is the main concept in learning about, from a physiology point of view, about fetal circulation. Let's look at the fetal circulation. Point to note, because in the fetus the lung is non-functional, it's collapsed, the placenta now is the source of oxygen for the fetus. So therefore, the umbilical vessels will be the highest or richest source of oxygen in the fetal circulation. Why? The source of oxygen is the placenta. Having said that, what would we expect to happen in a patient with fetal circulation? Let's visualize the fetal circulation. In so doing, it's easy for us to understand. In the fetal circulation, flow is coming from the umbilical vessels to the right atrium, then from the right atrium to the right ventricle. Of course, we have blood that is going via the foramen ovale to supply the upper part of the body. The main flow then continues to the right ventricle. The right ventricle in the fetus is the main pump. It can develop a systolic pressure of about 25 millimeter mercury. Blood then goes from the right ventricle into the pulmonary artery. From the pulmonary artery, most of the flow, over 90% of the flow, will then continue via the ductus arteriosus into the aorta. Just a small percentage, less than 10% of that flow will go to the lung to supply the lung in terms of feeding the lung. The lung is collapsed, so the blood is not going there for oxygenation, but just as a source of nutrient to the lung. Over 90%, therefore, will flow from the pulmonary artery into the aorta, and then from the aorta into the systemic circulation. This represents the fetal circulation. How is this different from your circulation or the non-fetal circulation, or you can say the normal circulation? Normally, blood will go from the pulmonary artery to the lung. As you know, from the lung, blood then goes to the left atrium, and then from the left atrium, blood goes to the left ventricle. This entire side to the right, or in red, is asleep in the fetus. The main pump in the fetus is the right ventricle. There is no need for the left ventricle to be the main pump because it's not receiving the majority of the flow or the flow from the lung. The lung is asleep. Now, when the child is born, pressure changes that will occur from the time the first breath and expansion of the lung, pressure changes in the lung, these pressure changes and pressure changes with the left ventricle would now result in the obliteration of the ductus arteriosus and the establishment now of the normal flow. The left ventricle becomes the main pump, developing a mean arterial pressure of approximately 90 to 100. This is what the normal circulation would now become. In some children, however, the ductus arteriosus remains patent. In other words, it does not obliterate. It stays open. Now, what do we have? We have the left ventricle assuming its role as the main pump, pumping blood into the aorta, which now has a mean pressure of 100. The pulmonary artery, receiving blood from the right ventricle, has a mean pressure of 15 to 18 millimeter mercury. As you can see, we now have a pressure gradient from the aorta to the pulmonary artery. Because of this now, we will have a reversal of flow from the high pressure aorta to the low pressure pulmonary artery. This reversal of flow is referred to as a left to right shunt. And as you can see, a left to right shunt, what kind of blood is going from the aorta to the pulmonary artery? Oxygenated blood. So therefore, this patient, this child, is recirculating oxygenated blood. What would you expect to happen to flow into the systemic circuit? Flow will decrease. This child, of course, will have hypoperfusion. The pulses, when you do the peripheral pulses, will be very feeble because this child, quite a large proportion of the circle of the flow is recirculating over and over between the aorta and the pulmonary artery. Now, back to the question we asked earlier. What, therefore, would you think would happen to the oxygen content in the pulmonary artery in a patient with PDA? And of course, if your answer was increased, then you are correct, because we are recirculating oxygenated blood into the pulmonary artery. And that's the important concept that we want to bring to your attention in terms of fetal circulation.